Hello, everyone, and welcome to the Practice Perfect podcast. I am your host, Jennifer McNamara, and I'm here with my lovely co host, Maya Turner.
Hello, everybody. Happy Wednesday. Happy hump day. Do you know what day it is? Wait, 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 wait,
Oh
wait.
no. Yep. We here, and it's definitely a Wednesday, guys. I am feeling that midweek rush to get things done before the end of the week for sure. And I know we have a lot going on, but it's always nice we can get together just to take a break and
Yes,
share, right? Share
yes,
something really new and cool with our audience, and also something, just reminders, right? Like that's what we're here to
yes,
talk about, reminders on today on coding.
yes.
And a really great episode today I'm excited for, because it's something that I deal with on the regular as a surgical coder. And for those of you out there that are surgical coders, you know what I'm talking about when you are trying to abstract from the path report. Yay! So exciting. Yes. And I think it's one of the topics that we don't talk about often, but it is integral into our role as coders, because we don't know the final say when something gets sent off to the pathology, the true diagnosis, right? Or the true nature of what the patient has is not seen until it's fully dissected and reviewed by a pathologist. So
Right.
yeah, I mean, maybe you've had that okay, now what moment when you're like, okay, I don't have a path report and I know that my code's going to make a difference
Yeah,
if I need to change it, right? So we need to understand what to look for. What is this path report thing all about?
yeah. I mean, I think one of the things that most coders need to get is that even though the physician says to code it as a malignancy, especially dermatology,
Mm, oh
I
my
know
goodness.
and they do it all the time, but you cannot code it as cancerous until you have that path report. I don't care how long if it takes forever for that path report, that code shouldn't go out the door. Period. You need confirmation. Yep.
Right. And let's just, you know, for a minute, I want to go back and and I don't have an image in front of me live. I probably should, but I don't. But take your minds back, open up your ICD-10 manual, and go to your neoplasm table, just for instance. There's a lot of terms on there that you're going
Hmm.
to need to understand. So if you're new to coding, you're taking a class, maybe you're taking Maya's class, and you're learning all about ICD-10. That's one of my favorite areas to learn. When I first started
Yes.
learning ICD-10 was the neoplasm table and all that. Of course, in ICD-9, when I learned, it would look a lot different.
Oh,
But
girl.
but
Oh.
yeah, so we have terms like morphology, right? So the actual morphology of the tumor, is it going to be malignant? Is it going to be benign, in situ? Is it going to be unspecified? We don't know until the pathologist tells us, right? And so once we actually know the true nature of that tumor, we start our coding journey, right? So we would go into, first of all, our index. We want to look up the term that is used on the path report. It might say adenoma, which we know is a benign tumor, or it might say sarcoma, right? They may use terms that are not in our neoplasm table necessarily. So we look up the term, and usually in your index, it'll tell you if it's a malignant or a benign type of cancer. Then you can go to your neoplasm table and find your body part, match it up, and then we're not done. And then we go to our tabular, right?
Yep.
All those steps.
Hmm.
How many coders out there do you think, in the true land of coding, live production, being pushed by management, just pull the code that gets put on the EMR?
A lot, especially if it's end of month. The
Yep.
close out, they push them out the door. Well, we don't have the path report. We'll push it out the door anyway. We'll just fix it. No, you cannot do that. That goes against ethical standards, truly.
So we're going to talk about, first segment, why path reports matter. So this
Yeah.
is the confirmatory information of that diagnosis. They might suspect something. We suspect malignancy. I prefer my physicians to say that, because I'm ultimately, at least on the procedure note, because that's going to say, okay, I'm waiting for the path. He doesn't know. He or she doesn't know. They might suspect it, but we don't really know until the pathologist confirms everything, right? You need that definitive proof. anytime you do a biopsy or any type of excision or you're removing tissue that needs actually to be reviewed. Now, it is true that it might be just benign, but it also could be malignant. And so we do
Hmm.
need to talk about what can happen, Maya, with the CPT section if we don't wait for the path report.
Well, there are certain types of codes. There's the excision for a malignancy and there's excision for a benign. And the 114 is for the benign, and then the 116 is for cancerous. So that's going to make a determination. And especially if
Mm-hmm.
you're dealing with more than one body part, right? You got to know if they're doing more than one excision, you got to make sure that you're using the correct category, the correct anatomical area that's associated with those codes. If you don't, you could be reporting the wrong codes and then in turn getting the provider an inaccurate reimbursement.
Absolutely. And also think about the fact that we have other code sets in CPT
Hmm.
that are
Hmm.
also looking at, excuse my voice this morning. Oh my goodness. They're also looking at um, things, terms like radical, right?
Hmm. Hmm.
That's a
Hmm.
term, right? Where they're usually, their intent is to remove tissue around the tumor because they need to get all the margins. And you'll use the word margin. I do plastics a lot. And so that's what they're looking for is, and when we're code for the mastectomy, the partial mastectomy, they're removing a part of the breast and usually they're looking for margins. They're looking
Right.
for the tissue around it, and they should say that when they're
Hmm.
doing a
Hmm.
partial mastectomy. If they're just doing a lesion excision or some kind of lesion on the breast or the nipple or whatever, it'll be a different code
Right.
because they're truly just removing a piece, an actual tumor itself, the whole lesion.
Right.
But if it's the partial mastectomy, they're looking at tissue plus margins, and and then the radical includes more. In ENT, we also have codes like for head and neck cancers that actually include the term radical. There is also that term in the ear, believe it
Hmm.
or
Hmm.
not,
Hmm. Hmm. Hmm.
when we have that going on. So we want to pay attention to that terminology in our operative notes. That's a really big trigger to wait for the path report.
Yep.
But I'm not going to lie. I mean, there are times where I do definitely not have it when I'm supposed to have it. Especially when I'm doing client work where I have access to certain notes. Like, so some of our clients that have us code for them, we don't have access to the EMR. So they have a secure portal. They give us the notes and we don't always have what we need. So I have to request, do you have a path report? No, we don't. It's like, well, I'm going to give you what I have, but this is only what we can code. There might be an issue later on. So I always
Hmm. Hmm.
caution them in this specialty that we're coding and plastics for real. If I don't have a path report, I really can't tell you honestly for sure what the diagnosis is. So it's a red flag for me if
Well,
they're
I'm
not giving me the path report.
I mean, and especially when you're dealing with excisions from a, integumentary perspective, malignant versus benign, because if the physician documents in the operative report that the path report does report that it's benign, and there is an interpretation of that path report in the
Yes.
note and the procedure, you are still able to code it
Yes.
because the physician is read the report and has placed it in the note to confirm the type of service that he's doing.
Excellent point, and that is definitely something to watch for because you want to make sure all you're looking for as a coder is confirmatory evidence. What you have in front of you at that moment is what you have. Now, you may not be able to always help the situation. You may be told you have to get it out, but what that means is you're coding what's right in front of you.
Yep.
That is your job.
Yeah.
If someone has told you to do it, make a note somewhere. Cover yourself.
Mhm.
Always a good idea
CYA.
to CYA, guys. Cover your, you know,
Advice.
yes, cover your advice. Cover your advice, ladies and gentlemen. And the payers are watching. So this is really important. The payer, well, they're always watching,
Yeah.
they're like they're the other big brother, you know, and
Yes.
yes, they're looking for mismatches between clinical indicators, what you're saying you did or you found versus what makes sense clinically in the documentation. Especially if they request records, they may want to request a path report. Again, those are things that happen. And on the like inpatient side, right? I don't really do that like all the time, but maybe Maya, you have some experience there where it's ongoing
Yeah.
and you may not have it, right? Because in the inpatient world, you can say probable
Hold it.
suspected, rule
Yes.
out, right?
Yeah, because you're using the same resources as if the patient has it. And that's the difference between inpatient because you're using facility resources to treat the patient. Whereas in the
Right.
physician setting, it's based upon the encounter and the definitive diagnoses.
Yeah, I mean, like, I was a huge fan of the show House. I don't know if anyone
Yeah.
ever watched that. I mean, like, I
Oh,
was
yeah.
like in love with that man. He was my old man crush. Oh my goodness, I loved him so much. And so Hugh Laurie, he's amazing. Anyway,
Yeah. Yeah.
so shout out. Anyway, so remember they were in that room. They had the big whiteboard, and they called it the differential.
Yeah. Yeah.
So, like, I didn't really understand what that was at first, but back in the day. So I was like, okay, I get it now. And so that's what they're doing. They're contemplating. And remember, you have an intensivist and a hospitalist on his staff.
Yes.
That's what
Yes.
they were, right?
Hmm.
And infectious disease, like that was what those types of physicians were in the hospital. They're hospital-based physicians, right?
Yeah.
And
Yeah.
so they
The
were
care
looking
team.
at, yes, the care team. They were looking at the differential as to what could be wrong. And how
Right.
many times did they get it right the first time?
Not always.
Not very much, right? So they had to actually go back and like, let's try this or let's try this. So
Yeah.
that's the world they live in. We don't live in that world in Profi. We don't
No.
live in that world in the office. We only go on definitives and the truth today, as Miss
Right.
Christine Hall says.
Yes.
Yes,
And
today.
otherwise, you're going by the signs and symptoms if you don't have the definitive diagnoses. So that is something
Right.
you also need to include when there is not enough evidence for a definitive diagnosis.
And that is part of your ICD-10 guidelines, your basic guidelines that say if you don't have a definitive diagnosis, you code to signs and symptoms. That was one of the very first things I ever learned. My very first job as a coder, certified coder, was dissecting diagnosis codes for radiology reports. And I'm really glad they put me there because it really helped me get really strong in the ICD-10 arena or ICD-9 back then in the diagnosis process of coding because it's very different than CPT.
Hmm.
I know that we do a lot of audits, Maya, and very rarely do the clients ever ask us to audit ICD-10, which is kind of worrisome to me sometimes. They're like, just get us the level, like just do that. But it's like they don't realize how important getting that right is
Yeah.
and how
Well,
down the road it's going to matter.
Well, I mean, I think when you're dealing with ICD-10 and you're dealing with Medicare, right, you have the Medicare risk adjustment, and then that's
Right.
where
Yeah.
that comes into play. So, I mean, and those kind of risk out when you're dealing with those. So, I mean, it depends on the environment, but again, a lot of times these payers are really savvy. United Healthcare is
Mhm.
very, very savvy, and they have published guidelines about
Yep.
how they're going to reimburse certain things, and you need to make sure that you watch your payer because your payer they could I mean CPT and CMS they vary
Oh,
a
yeah.
lot when it comes to certain payer policies. So, and some of them mirror, but again, your payer policy is going to gauge how you're going to react and how you're going to necessarily deal with they're going to reimburse certain things.
Right, exactly. Well, let's have some fun, guys. Let's add our path report to the stage here. So, what I want to talk about is this path report, and it's got the diagnosis at the top here, and it shows that there is, I don't know if you can see it clearly on your screen, but it says there's an infiltrating ductal carcinoma, moderately differentiated, right breast, core biopsies. So we know exactly what they did. They did a core biopsy, so that would be what our CPT would be, obviously. But this is the actual diagnosis, right? It shows the microscopic where they actually looked at everything, and it's just the true nature of that. And they have the pictures, right? Sometimes pictures are great. I don't know what I'm looking at when I look at that. So pictures all the time don't really matter to me. I'm not a medical professional. I don't read images, so it's not my world. But it's nice that they're there. It's good.
Right.
The clinical history is there. The sites. I want to
Yes.
know what they received and where it came from.
Absolutely.
Now, there are codes in CPT in the path and lab section for pathology billing, right? For them
Yes.
to report their service. So you
Yes.
do need to know the
Yes.
actual procedure that was done for those codes. So you might be
Right.
wondering, well, it doesn't matter. I just have this tissue, right? You got to know where it came from, how it
Yeah.
was taken, where it
Yes.
came, yeah, the actual laterality, everything. That's really important. So this gives us a full picture of that. And then we're going to code that exact terminology up there. We would either code the physician's terminology if we don't have a path report, or the symptoms. If it's not definitive, we code the symptoms. But if we have a path report, we code exactly what they say. Now, it's also been noted in some cases where I have audited, and I have seen them code every single tiny diagnosis that exists on that path report. And it's insane. And it just, what it does, it just mucks up your billing, makes no sense to the payer because the provider didn't document any of that.
Yes.
They're not
And
concerned about any of those things whatsoever.
and then you have to deal with the sequencing, right? I mean, I can't
Yes.
tell you when it, oh my gosh, sequencing of ICD-10 diagnoses and even with the procedures, right? The severity of the procedure or the highest severity always is to go first. However, you have to
However,
watch how that claim goes out the door because I can't tell you how many times where I'll see something in the note and the diagnosis order, the sequencing order is all over the place. And you're like, what? So you get a denial and it's not pointing to the right diagnoses. It's just, they're just going all over the place and it's not appropriate. And especially when you got people who are just pushing claims out the door, they're not caring about sequencing. They're not caring about making sure that the highest dollar valued code as far as CPT goes out first. So that could adversely affect your reimbursement for sure.
yeah, I was auditing oncology practice once, and their coders were adding every single history code.
Mm, mm, mm,
And
mm.
it was, here's the deal. Here's the deal. History is important in oncology, 100%. But the important history codes that go on the claim need to make sense for what is
Yes.
being done. Okay. So yeah, they have family history of prostate cancer, family history of breast cancer. Like they have all of it, right? That's bad. And you think about the real person that has all that, they're dealing with a lot. So yeah, think about the person. They're dealing with a lot. But from a reimbursement standpoint, you want the claim paid. So documentation wise, it's great. They have been very thorough and they have given maybe to stand up in court, or maybe there's other information that or the things that that would be needed for, but not for reimbursement. For
Right.
reimbursement, we only need what gets it covered and what is true for that clinical encounter that is relevant.
Right. And you know what really gets me is the chronic conditions are relevant because it could affect the healing, it could affect the
Yes.
treatment, but it shouldn't be primary. If there is an excision, the primary diagnosis shouldn't be hypertension. And then the third diagnosis is a malignant neoplasm of the breast or malignant neoplasm. It's not going to work, especially if the pointers on the claim don't reflect that service. So
Yeah.
coders that are out there, make sure that oh, what about this, Jen? You got an unspecified diagnosis for laterality, but you got right or left breast on the CPT code.
Oh, I love it. Happens all the time because guess what?
Oh,
The doctors are going 90 miles a minute and they just pull whatever comes up first
yep.
in the EMR. The coders grab it, billers grab it, let's go. So we get C18.9. Makes no sense, right? Drives me nuts. When you know it's like literally documented that it's exactly what that path report said. It is that ductal carcinoma, the DCIS, which is not necessarily a C code. So you got to know that too. Some of those are not cancerous, and the way they word it is very important. It gets you the right
Yes.
code. So the
Right.
physician might just grab a code, not realizing what they're grabbing. It happens all the
Yeah.
time, and it
Yeah.
just gets sent through.
And yeah, I'm a big fan. I mean, and I always reiterate this to class. If there is laterality in the report and you need to express laterality in the diagnosis code as well as a procedure, they should match, period. If they don't match, you're going to have a problem. And it could be more problematic from an audit perspective because you're not being specified. You're not specifying, and there's more specificity from other providers who follow that patient. So that's very, very important.
Right, exactly. And there's also something too, like I code breast, like I said, so I know that area of the body pretty well because of having to deal with all of and every day I'm coding it. So when I look at things like there are certain diagnosis codes for breast cancer that you want to get on there. So you want to make sure you make it count. So we definitely want the main reason that procedure was done, the cancer, whatever it is. And if it's breast cancer, we also have the new codes for BRCA that have
Yeah,
come out.
yeah,
And we also have the estrogen
yes,
receptor codes.
yes,
So those are
yes,
additional informational codes, Z codes, that you want to make sure get on there. So
yep,
those are good things to remember, and you need to get to know your specialty. What codes are going to give the payer information, where they're not the primary code, but they still need to be accompanying the main code. Don't just slap on that main cancer code just to get out the door. Do your diligence and know your specialty. Know what ICD-10 codes tell the whole story that are documented, of course, and that actually help the reimbursement, help show how sick your patient is
right.
and what services they're possibly going to need down the road, because what we tell them now affects them later.
Yes. I mean, and also you have to worry about, not worry about, but you have to make sure that the documentation, especially when there's a path report, that there's a metastasis. If there's a metastasis, you have to make sure that it is also sequenced appropriately when it comes to ICD-10, because again, that's going to affect how the patient presents in the hospital. It's also going to affect what code should be presented first if the treatment is for the metastasis versus the malignant site, the primary site. So you got to be very careful when it comes to that. You have to make sure that whatever the documentation reflects, that your ICD-10, as far as laterality and the severity, as well as the primary versus metastasis sites for your primary and secondary codes.
Oh, don't get me started on that, girl. It's
Oh,
crazy. Like when I'm teaching that, I have to slow down and make sure everyone gets it, because it's one of the biggest misses on the test and just in
yes.
general, like the actual sequencing of those things.
Yeah.
Um, so let's go back to procedures for a second.
Okay.
The size. This is the one of the
Uh-oh.
things that we often miss is the
Yeah.
clinical size, because yes, the pathologist is going to tell you on that path report the size of the lesion. We know this.
Yes. Yes.
But what happens in the transfer, Maya,
A lot
from
of
the physician to
times
the pathologist?
you sometimes they're not indicating the margins, so you have to make sure that if the doctor documents the margins in the report, that you include that in your code, because you have to code the excised diameter plus the margins.
Yes.
Even if they don't
For the
tell
lesions,
you.
absolutely.
Yep,
Hmm.
for the lesions, you have to include that. And if it's not there, you are inaccurately reporting and could cost the doctor dollars because you're not
Hmm.
reporting the actual size, because it goes by size for the excision and anatomical sites.
Right. From a 3 to a 4, even the last digit of that code, it's very small difference. It can go from what, 3 centimeters to 3.2 very easily, right?
Yeah.
So we
Yes.
need to make sure that we get that information in there. Now, the other thing is, and when you're new to coding, you may not realize this. So if you are new, this is something you want to remember, is that when it goes from the physician to the pathologist, it will shrink.
Oh, yeah, that's right.
So
Yeah, yes,
you
yes, yes.
want to take, yes, and that was what I was getting at, and it's fine. I was like, I don't think she got
Right.
what I was putting out there. I don't think she smelled what the rock was cooking. I don't think she got it. So anyway,
Oh my gosh, I used to
so
love it when he said that, and his eyebrows used to go way all the way up. I'm sorry.
and it's so old school. It's like really, yeah. But no, it gets smaller. So you
It
always
changes
take the
shape. Yeah.
size from the physician. So that means you got to talk to your physician, guys.
Yeah.
Um, I'm gonna get on my soapbox right now
Uh-oh.
because one of my biggest pet peeves is you supervisors out there who think that you
Uh-oh.
are the only one that gets to talk to the physician. You need to stop right now being the middleman between your coder and the physician. You do not most of the time you do not know what's going on in the op note. You don't know how to code most of the time. Maybe you do, but that's not your job. Your job is to manage employees and to get them what they need. What they need is to talk to the surgeon. They
Right.
need communication. If you're working in a system like Epic, which I've done several times, it's the
Yes.
silo. They put their coders in a silo. I worked in an environment where I wasn't allowed to talk to the surgeon. I had to message the manager, and it was ridiculous.
Yeah,
They
that's
have
the
no idea what to tell the surgeon that I need. No idea.
well, in most instances, when you're dealing with large coding departments, there should be a protocol for querying the physician when it comes to size. There should be. And in Epic, there's a direct messaging system for the physicians in order for you to do that. But unfortunately, like you say, it's very guarded, it's very siloed. And unfortunately, information can think about that telephone call that you do across the room when you're a kid. You got used to the phone
Yes.
cup, and then you go around and everything. And by the time you get there, it's like, well, I want to, especially with the Bill Cosby show, even though he's not the
Yeah.
best, but I mean, in the Bill Cosby show, and they had like Rudy, and then he said something about the
Rudy.
leukocyte. Yes, and by the time it got back to him, it was something completely different. So interpretation, perception, and communication is going to be key when you want to code something accurate. If you don't, then you're going to miscommunicate to the insurance company, right? And then there's going to be problems because you're not getting what you are intended for the procedure you just performed or they performed.
Right. So, really quickly, let's think. We've learned, okay, what the path report is. We have discussed also what to make sure that we code and don't code. But let's just like talk out an example here. So we have a provider who removes a lesion on the forearm. What I know so far is it's the location. Now, I don't have the laterality of my procedure. I just have the forearm. So what's a question I'm going to ask my physician? What side did you do this
Sure.
on? Does this
Yes.
patient only have one arm? Like, I don't know. I have no
Yes.
idea.
Mm-hmm.
And they say likely melanoma, right? So it
Nope.
might be skin cancer. So I can't say that for sure. I have to
Nope.
get the path report. And so in this example, I get the path report. On the op note, it says 2.3 centimeters. I want to make a note of that. We just talked about that, right? 2.3 centimeters means that's the size the physician is excising. We're
Yes.
going to say that they are telling us that that's all we have. We don't have margins. So if that's all we have, that's all we have. And
Yep.
we can't go beyond what we have, right?
Exactly.
So when we get the path report, it says basal cell carcinoma, margins clear. So then what do we do?
You code the
We
basal cell carcinoma and you code it as malignant.
11604.
Mm-hmm.
Good job. So we have that information. So good stuff to think about when we think about the codes and what we do with that. Now, let's say that it says the path report said lipoma, benign soft tissue tumor. That's going to change the diagnosis code area we go to. It'll be a D code instead of a
Yep.
C code.
Yep.
And it'll be a 114 code for the CPT instead of a 116, right?
Yes. Yes.
Right. I also code for gastroenterology, and they have different types of things they remove, the polyps, right, from the colon.
Yes. Yes.
So those are benign neoplasms. If you go to your behavior, like say they call it a hyperplastic polyp or they call it an adenoma, usually you want to take that terminology and you want to plug it into your index, right? It'll tell you whether or not that is benign or malignant. I will tell you both of those are benign.
Yes.
Both of those are non-cancerous. Polyps in general usually are unless they become cancerous, but mostly they're benign. So it's a D code if it's an adenoma. It's a K code if it's a hyperplastic polyp, where there's no morphology of a tumor that exists
Oh,
in the tissue.
yes. And another thing that I'd like to add is remember, if the biopsy is part of a significant procedure where they're already there, you
Hmm.
cannot code it separately. You cannot code it separately. So
Yes,
that's
and we do
something
have our, yeah, absolutely. We have our modifier 59. And so caveat, we do want to make sure we understand the proper use of that. I see it all the time where when you're coding for GI, you have
Yep.
the snare 45385 and the
Yes.
45380 for the biopsy.
Yep.
Now
Yep.
CPT or it's called 59 says you can do it for separate lesions. Medicare has specific guidance on this exact example where non-contiguous lesions, which means are not touching, can be unbundled in the same organ if they're non-touching. So we have to look at that as well, non-contingent. So normally, yes, if it's the same region, you would not unbundle it. Or it's a separate lesion, you can say that. But sometimes what they're doing the 4538O for is not a lesion. They're not biopsying a lesion. They're biopsying something else. So
Yep.
there really isn't any grounds for you to add a 59. So you really want to watch the reason why they're removing that or they're doing the biopsy in addition to the snare technique.
Hmm.
It may
Hmm.
not be billable or unbundled because you didn't have a reason to unbundle it.
Yep. Yeah, I mean, and you got to watch that, especially with your NCCI edits, right? It'll tell you if it's a 1, a 9, or if it's not
Yeah,
applicable. So you have to watch your NCCI edits when it comes to those things when you want to code it, but you're not sure.
right, exactly. So again, we have the procedure note, we have the path report, we have the claim. Like compare those things. When we audit Maya, those are the three things we're looking for, right? We're looking for those three things.
Yes, absolutely. We're looking for the path report to validate if it's malignant or benign. We're also looking at the excision to make sure that the size is appropriate for the appropriate anatomical sites.
Right, exactly. And it may not be as possible in the real environment. I'm not saying like Jennifer says you have to do this, but from a compliance standpoint, and again, CYA,
See,
you
cover your
know,
advice.
cover your advice. Just make sure that in some way, let's just say you're concerned about the outcome, what might be because of what you were told to do, or you're just uncomfortable with the workflow in your organization. Document everything, email everything.
I can't tell
If you
you.
just, yeah,
Yes. I was just going to say, it's important to cover your advice. I wouldn't say advice normally, but yeah.
it's all right.
So
It's all right.
it's important. Trust me. Covering your advice and having a trail of the decisions that are made that are unethical or possibly unethical could be the difference in a lot of outcomes.
Right. There have been cases where coders have been lumped into physicians in fraud cases. They've
Yep.
been part of the fraud. And you could
Hmm.
be called to testify, and you want to make sure you're not part of the problem. So make sure you have covered yourself. Email everything. Don't go to the water cooler and have a conversation. Don't go up to someone's desk and ask them a question. I mean, you can do that, but it's in your best interest to email everything so you have a trail of conversations. It's a really good idea. Have a documentation trail so somebody
Yep.
can go back in and know exactly what was said, what the question was, what the answer was, who asked the question, who answered it, what did they tell them, where did they get the information from, and like that's all the stuff that you would look for in a case like that.
Yes, absolutely. And I've seen it with my own eyes where things have been done incorrectly. There's that verbal handshake, and then everybody walks away and nobody documents what's happening. And then next thing you know, you got somebody, a blacktop knocking on your door. So be very, very careful of who you talk to, why you talk to them, and the outcome of the result that, was out of that conversation.
Right, exactly. So we got a lot discussed today. I think we got through a lot of information.
We did.
Yeah. Yeah, I think it was really fun to like just dig into this topic and get myself remind myself of why I do what I do, why I love surgery and all the nuances in the surgery world. So if you're interested in coding the surgery world, contact me. I can give you all kinds of advice. I love surgery. Maya works mostly on the primary care, behavioral health, that side where it's mostly E&M, which I love too. But there's something really special to me about working with surgeons. I just love working with surgeons and I love what they do. I've gotten to see surgery happen in the OR and
I have
it's
to.
like it's just so fun. Like I love that. Not everyone can handle it. I'm telling you what. Some people
No.
get a little queasy, but I love it. I love it.
Yes, yes, yes. But I think there's something coming up, isn't it, that talks about surgery that you have coming up, Jen?
I think there might be. Yeah. So on June 6th, we have the General Surgery Coding Summit, and we have so much information out there about it, guys. Follow us on Facebook, follow us on LinkedIn, Healthcare Inspired LLC. Great stuff. 8 CEUs. We have sold so many tickets this year. I'm just in awe of these general surgery coders coming out and buying their own tickets and being willing to invest in their own career and their own
Absolutely.
education. It's been
Yes,
so
yes.
rewarding. Yes. And swag bags go out Friday, guys. So remember, you have until May 10th to purchase your ticket. You can go to healthcareinspiredllc.com. Under events, you're going to see the general surgery coding summit. You can purchase your ticket there. And swag bags will be filled with all kinds of fun stuff. I'm going to actually show you a picture of my swag bag so you can see this. Oh, you know what? Let me turn this off real quick. See, I don't know if you can see it. Ah,
No, I can't see it.
it's not going to show it. Okay. It's really cute, guys. I'm a surgical coder. Not all heroes wear capes. It is really cute. You can purchase that actual bag, though, on our new Etsy store, guys. We have a sister store called J Inspired Threads that I started. I'm really excited to partner with my own company and start J Inspired Threads. And so there's all kinds of cute merch, guys. There's tote bags, there are phone cases, coffee cups, t-shirts. I'm gonna add in some other merch like typed as we get further into the year. So like going towards the end of the year, we'll have some sweatshirts and some fall time stuff. So keep an eye on that. And we're gonna add some non-healthcare stuff too. Some things for you CEOs and you business people that aren't necessarily coders and billers. Some fun stuff like that. Our brand new product that just launched is our bag for Nurses Week. So check that out. It says Ivy League faculty with an IV at the top. It's really cute.
Oh, that's
It's
cute.
super cute. I'm really excited to launch it for Nurses Week. So all you nurses, go grab your Ivy League faculty tote bag to carry around the hospital, anywhere. Actually, it's really fun. So check that out. So remember, May 10th is the deadline to get your swag bag for the conference because we ship those out very, very soon. It will have all kinds of fun stuff in there, survival kits for the conference. I'm really excited to send those out to everybody. And you can also check out the shop. It's really, really fun. We'll have more products launching very, very soon. So stay tuned for that. And next week, guys, we are going to dig into a topic for all you billers out there and those of you working with patients. We're going to understand statutorily excluded versus non-medically necessary. So we're going to dig into
Oh.
that topic. I recently wrote an article for NAMUS that will be launching soon, so it's kind of like going to dovetail on top of that. So you can check that article out. That's going to be dropping soon. And then also the podcast will talk a little bit about that. We'll talk about the ABN form. We'll talk about statutory excluded. We have so many good examples to talk about with ophthalmology and podiatry. So it'll be a fun topic next week. So stay tuned for that. Thank you everyone for joining. As always, you're always great audience. We thank you for joining in and thank you for engaging with us. And shout out to my buddy Cameron Llewellyn, who apparently thinks that it's his favorite show. So thank you. Thank
Hey,
you for
Cam.
shouting out. Hey Cam, thanks for shouting out that's your favorite show because we're glad that we can make you happy. So thank you so much, Cameron, for being one of our biggest fans. So thank you guys. Have a great one. We will see you next week.